Okay, so this is a 3 developmental issue lectures in one video. There will be timestamps below with different topics so you can jump around. You can learn the content in any order. We'll be talking about it in a specific order in class. But for the sake of quizzes, the content is a little bit more applicable and more intervention-y and more question-based for like how you would interact with kids rather than the actual like specific details of each disorder. So you'll have access to it and all, but if you don't cover everything by quiz 3, that's okay. You should still be able to function pretty well. So we're going to start with DLD, which is developmental language disorder. This was commonly known as SLI or speech language impairment before, but now the term that is used is DLD. So if you see SLI, just know that's a little bit older. Some people still do use it, but DLD is the same thing. So it's a condition characterized by extreme difficulty in language acquisition in the presence of otherwise typical development. So it's like a lifelong learning issue where some people have extreme difficulties in language acquisition. So they compare this to 2 different types of ages that are used in other cognitive tasks, like tracking objects with attention, other things like that. So there's your mental age and your chronological age. So your mental age is the age that you typically function on cognitive tasks. So that could be attention tracking, that could be decision making, that could be reasoning and other things. So someone might have, say, a mental age of 4, even though their actual age, their chronological age is 9. So if there's a gap there, then you may say that, okay, there's a developmental delay or perhaps even a disorder if it is lifelong. Delays are usually temporary, disorders are long-term. So is it true to say that children with DLD have a gap between their mental age and chronological age? Well, that's a bit of a difficult question because there's not necessarily an established relationship between cognition and language. So, if mental age is defined strictly by their cognitive abilities, then we'd expect language to be at the same point. But that's not actually true. Some children have better language skills than cognitive skills, and some kids are in the reverse. The cognitive skills are better than the language skills. So, is mental age language acquisition? It's a little bit hard to tell. Again, children vary in their levels of intelligence, and perhaps the mental age of a child and their current trajectory in language acquisition is so low that we don't see any sort of language disorders. So if we're going to talk about language acquisition and developmental delay, we should really be talking about the chronological age gap with language acquisition over the mental age gap. So, I mean, if a 9-year-old child has the language development 4-year-old, then that chronological age is quite important rather than like what is their ability to do other cognitive tasks. Okay, so we're going to be talking a lot about different disorders, so we should know what a clinical marker is. A clinical marker is any feature or characteristic that occurs within a child of a disorder. So in this case, we're talking about children with DLD. So like one of a very common markers is with grammatical forms or verb tense. So children with DLD will often make issues with tense and forms a little bit longer than other kids. It could be like years in terms of their difference. So we saw a lot of examples with the data analysis too, she go versus she goes. So children with DLD would say she go for a lot longer than typically developed children. Now, how do we identify this? We can use nonsense word repetition tasks. So these are called NRTs. These are basically you just give children a bunch of nonsense words, not real words, and you ask them to repeat them either right away or remember them and produce them in the future. So if you have a child with DLD, they're going to perform worse than typical children. So they might have difficulties remembering those words or producing those word forms. And you can really check phonological development with these, and also just word, like not necessarily word recognition, but if you think about template theory, putting those sounds together to form a word. We know there's a lot of difficulties when understanding a word and producing it rather than just individual sounds. Okay. So, of course, if it's a sound test, we should also be quite aware that just because a child doesn't perform well, might not mean that they have DLD. It could just be issues with phonology in general at that point. So we need to be very careful in terms of like what age this task is used. So when they're older than 5 and they mastered phonology, or not mastered, but do very well, then this test is a little bit more useful. Okay. What else do we see with children with DLD? We see sentence repetition and imitation. So we'll talk about autism, of course. So echolalia, where you repeat things, but this is very common as well with children with DLD. You're going to see a lot of overlapping symptoms in these different conditions. So in order to imitate a sentence, they need like long-term memory, they need knowledge of grammar. So, if they have developmental language disorder, they might have issues with cognitive abilities too, or they might just have language issues that take a little bit longer to imitate a sentence. We know that children imitate sentences in their own grammar. So just by seeing how they imitate sentences can kind of tell us where they're at, especially if they're a 9-year-old and they're still like in the telegraphic speech era when they repeat sentences back. We know they're limited by that. Or if they have other cognitive issues with memory, they might not be able to retain the whole sentence depending on how long it is. So this overlaps a bit with autism, especially for sentence imitation. Not necessarily how well they do it, but how often they do it. But just think of this as, can they produce the whole thing, and what do we see in their grammar? And then if we take a look at it from that angle, we can use this to separate DLD from ADHD or other disorders. So you might think, okay, well, DLD, we can just do some language tests, right? And if someone has an issue, it'll very clearly show that they are delayed. Okay. But that might not be true. So if you think about any sort of bell curve for any test, it's usually like this in terms of population. So typically developed children are probably going to be somewhere within the first standard deviation, so 68%, in fact, maybe even 95%, but there's some range of normality here. Let's not pick a specific percentage, but some range of normality. Now, children with DLD, depending on their chronological age, may fall still as normal. But you might see a child, let's say, in this position instead of somewhere in the middle or above. And as children get older, maybe they move a little bit more to the left over time. But at a really young age, they might still appear normal. And when I say normal, I mean typical. So I mean normal in terms of like where on the curve they are. Okay. So that's one issue. Another issue is that a language test might not capture the specific difficulties that they have. So maybe they can speak really well, but when they have to produce this on paper or with reading skills, or maybe they're in large groups, they may start to have issues functioning there and might show a little bit more developmental issues in language in those areas. So typically, if you have a child with DLD, they can acquire a lot of aspects of language, but they just need more practice, more stimuli. So they require a little bit more input and practice with that input. Okay, so what can cause DLD? Well, we don't know, of course, the exact cause of any of these disorders really, but we do know risk factors. So if you have parents who have DLD or communication problems in general that would reduce input, your risk factor for DLD is a little bit higher. If you're born later, you have a higher risk of DLD. Of course, that risk isn't like a huge percentage. It's just significantly greater statistically than, say, a firstborn child. Parents with lower levels of education might give higher risk to DLD, although I'm pretty sure there are other factors that would explain this. So this could just be one of those extra factors that are found because it's a confound for something else. Lower socioeconomic status, which is usually quite related with parental level of education, and also your biological sex. So boys are typically at a higher risk than girls. Okay, so Some key terms to note here, and I mentioned this briefly, well, I hinted at it earlier, is there's a slight difference between delay and disorder. So, developmental language disorder, when you look at specific symptoms, you might call it like a delay. And sometimes that's appropriate. But when we talk about the the label on the child as a whole for this particular issue, it's a disorder. So a delay just means it's slow, but you can catch up. A disorder usually means that it is a lifelong, so it's much longer term. And there's a significant difference between children with DLD and typically developed children. Okay. So in other words, like there's no catching up. So these children with DLD, they might pick up morphemes in a slightly different order and struggle with certain ones and never really fully acquire them. They might have extreme difficulties in one area of language, but maybe not in another. So um, if we think about, let's say, syntax and phonology, typically phonology is acquired and done really well a lot earlier than a fully developed syntax system. But a child with DLD might be totally fine with syntax and acquire it at a usual rate, but then with phonology, they really struggle. Okay, so DLD, this is a blanket label, but there are a lot of different subgroups, as you'll see with every disorder. Not every child is the same, and that's what makes a lot of the diagnoses difficult. So there's two very common subgroups of children with DLD. There's children with comprehension and expression difficulties, and there's children with only expression difficulties. So this is like a general trend. So it seems to be the case that if a child has comprehension difficulties, then they get expression difficulties, but not the other way around. So it does happen where someone has comprehension difficulties, but not expression difficulties, but it's very rare. So here's just some different subgroups of children, and you can see an X in the issues that they have. So if they deviate from a typically developed child, so maybe there's a group that has difficulties with expression, comprehension, phonology, socialization, and gesture. And maybe there's another group of children where it's just expression and comprehension and gesture. Or maybe gesture is fine, but it's just expression and comprehension. So there's a lot of different subgroups here. Obviously, this is not a full, complete picture, but we do not treat every child as the same. We need to analyze and take a look at every single different aspect of language to really understand what their individual issues are. Okay, so there's some risk factors, but let's talk about where it might come from. So people have suggested that you have like a neurological basis for this. Like maybe there's something in the central nervous system that is different from typically developed children, or specifically issues with the left cerebral hemisphere, um, where like a lot of language is stored. If you take neurolinguistics, you can get into the detail there. Let's not talk too much about it. But the left cerebral hemisphere is where language is very strong in most adults. If you're left-handed, there's a low percentage. It's in your right hemisphere, but it could be something there. So we don't know specifically, but these are some decent guesses. It could just be an input and output thing. So maybe there's not enough communication between a parent and child or between children and other children to actually be able to abstract these language rules. So syntax might struggle because they're not getting enough sentence input at all. Or phonology might struggle because they're not getting a chance to speak that often or practice. Okay, so this is not necessarily the best indicator because there's so much variety among children with DLD, but it could contribute. You may see cognitive deficits here. So, what people have observed is that hypothesis formation and testing and representational thought can be linked with DLD. So, if children have difficulties creating these hypothetical hypotheses and testing them, or thinking about things more abstractly, then they can have difficulties with some aspects of language. Okay, if you take a look at nonverbal IQ tests, overall, there seems to be a tendency where children with DLD have lower nonverbal IQ tests. But again, this is just a trend. This varies a lot for children. The statistical correlation is not super strong, but there's just like a very small correlation that's been detected. And in general, IQ tests may not be the most reliable thing. After all, this does rely on mental age, and as linguists have said, like this is not necessarily the best tool for DLD. Okay, a pretty big suggestion is just information processing difficulties. So children may not be able to take in much information at once. So maybe they're limited in the capacity of information, or maybe they're limited in the speed at which they can process that information, which is directly going to affect how much can be stored in working memory, which how much goes into long-term memory. Okay. So we do see children that have difficulty with processing non-linguistic information. So maybe just sounds in general or different visual aspects. Or children who take a little bit longer to understand phonological information. So they might hear a word and their processing time is quite slow compared to typically developed children. Okay, so these are just 4 suggestions. We don't specifically know where DLD comes from or the specific issues that are like apparent across every child that has DLD. But these are like 4 different things that could contribute to individual children. Of course, what I should say before moving on is that like a lot of these disorders, like they're not isolated. Uh, they're not isolated disorders. Usually, a child with DLD will have other like comorbidities. Like they'll have other issues, like either cognitive. I mean, in some cases, physical. Again, children vary wildly, but usually a child does not just have DLD, and then the rest of them is like totally typical. Okay, so then how do we identify children between 18 and 24 months? We saw that if they're at least 5 years old, we have like a nonsense word repetition task that could be used. But for younger kids, this obviously isn't too useful, and same with imitation because they're very young, like they're not yet producing full sentences. So some things we can see are there's no vocabulary growth spurt in 18 to 24 months. So if you remember the chart of word acquisition, they learn a lot more words starting at 19 months in typical cases. So you might not see that burst. They might not yet be at the telegraphic speech stage, which they should be at this age. And they might be talking very little. Although this one is questionable, it overlaps with a lot of different disorders, not just language, but even personality. They may have very tough home lives that, you know, or different home circumstances that affect how much they talk. Okay, so these particular issues are not going to guarantee someone has DLD, but they could be indicators. They're not the best indicators. Of course, very young, it's very hard to find for sure because what we see is that a lot of children may experience these as delays, but not as a disorder. So you'll see like issues happening at 3 and 5 years old, where some kids will fall behind from their peers, but they will catch up. Okay, so if you have 2 kids, maybe this is like kid 1, it's normal, 3 to 5, and then you see someone is like at 3, they're like stagnant a bit, and then they might catch up a little bit, but then at 5, they have some issues, but eventually like they'll reach the same point. So this might be a delay and not a disorder in terms of like some kids that have this. Okay. On the other hand, children who do seem to catch up might not actually be catching up. What might be happening is we see this pattern, and then at like 9 years old, suddenly, when kid 1, who is typical, is like up here and has been like up here for a while, maybe a kid with DLD has like had a little growth spurt and then they're like stuck at a lower level later. So just because it looks like a kid might be catching up, it doesn't necessarily mean that they don't have DLD. So like it's very hard to consistently identify children at a young age. And even if you monitor over them if you monitor them over time from like 3 to 5 to 6 years old, it might look like they have a delay that is caught up, but it still might be a disorder in the end because they might fall behind later. Okay, so what if you're a parent who is worried about your kid? Okay, so like, does my kid have a delay or do they have a disorder? So what you can do at home is you can just check all of their language skills. So you're not just taking a look at their vocabulary size, you're taking a look at their sound development, their syntax development, their semantic development, their pragmatic development, like you're assessing everything. You're not comparing your kid to other kids before the age of 6 or 7. You're doing it around those ages. Um, like that's when children are typically very close to the same language ability. They have a very good control over their phonology, a very good understanding of morphemes, and they are producing full sentences with some errors, but usually pretty well. So if they're falling behind at age 6 or 7 compared to their peers, that might be an indication. It's good to do it with their peers themselves because it could be the same socioeconomic location, same type of status, depending on what schools they go to. So you get a really good comparison there. And that might be, again, an indicator. And you can check to see whether like nonverbal things are delayed. So reading, writing, spelling. It's not just, speech that can appear as delayed or as a disorder. It can be written as well. Of course, if you find any one of these things, there could be some other things going on. But again, these are just indicators. So I have some charts from textbooks with different things you can see. I'm not going to talk about all of these, but we can point out a few of them. So, for example, children with DLD, when they're babbling early on, they kind of stay in this like non-reduplicated babbling stage where they're not getting these CVC syllables. They're just open and they're not changing the consonants. So it's very like ba, 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 rather than like ba, da, na. We do see, I guess that's really the only interesting thing here to talk about, in my opinion, for babbling and phonology that is um, like very clear from what we've seen in previous lectures. In terms of socialization, we may see deficits in social skills, but again, you might see this with children with autism too. You might see them have overactive and difficult to manage. You might have some ADHD symptoms there too. So again, like it's socialization behavior. These can be indicators, but it's not giving you a guaranteed diagnosis. Comprehension, you're going to see comprehension delays. In terms of vocabulary size, you might get lower verbs in early vocabulary. And you might also get, when you look at their verbal development, the verbs that they're producing are not the less frequent ones. They're only like the very high frequency ones. So in other words, like when you think about are they learning these from few inputs? No, they might be having difficulties with few inputs, so they can only really master the verbs that have a lot of high frequent input. In terms of narrative production, we talked about stories, but even with stories for children, it might be much shorter and less detailed than kids of their age, and they might have a lot of difficulties with understanding the time events of stories. So again, these are just some things, and to remember, these are just, indicators. They're predictions or warnings. These are not diagnoses. So children need to be evaluated using different types of language tests, and we'll see an example at the end. Okay, so behaviorally, you might see some issues here with reciprocal interaction. So this is when a child is interacting with somebody else. They're basically doing the same thing. So playing patty cake, for example, very classic game. Any issues with joint attention or understanding when certain things are happening using cues like gestures. So they might just have difficulties with that communication in terms of their actions. In terms of semantics, again, smaller vocabulary, slower vocabulary development. But if you take a look at the word meanings, they may also have less depth of knowledge about word meanings. So maybe they know like a grammatical item like but they don't quite have the same understanding as a typically developed child. So they're not using it in all the right locations. So they might not know that it's like uniqueness and existence, which adults like inherently know. So they might not quite understand that. They may also have a lot more delays in terms of actually finding the words they want to say. Okay, so this is called the tip of the tongue phenomenon. In adults, usually you know the word, but you can't find it. It happens usually not too often, but for children with DLD, it may happen a lot more often. In terms of conversations, children with DLD may have difficulties initiating conversations. They may be less responsive to peers' attempts to initiate conversations. So they might just not want to respond. In terms of turn taking, they may have difficulties with timing and being irrelevant. So just, difficulties there. Um, and there's some information here on clarifying and repairing. So the only thing I want to point out here is that children with DLD may not ask for clarification. So even if they don't understand something, they might not ask you to clarify, which is again why it can be a little bit difficult to identify children because, is this, if they don't respond to something well, think about it like, is it more personality based? Are they just not responding because they don't want to? So more like affective emotive, or is this just a language issue? So you might think if a child is asking for clarification over and over again for what words mean, maybe this is a sign that they're having difficulties with language and they have a disorder. But it could just be that someone who's asking is just, interested or wants to know more, while a child who doesn't ask, it's because they have difficulties. Okay, so those are a lot of different indicators that we have. Again, we're not diagnosing children, we're just describing. So how can you intervene? Well, one thing that can be done is called an indirect intervention. So this is like when you're not taking a child to see a therapist directly and you're not hiring someone. So this is just something you can do as parents, which is a lot less costly. Okay, so these are very typical strategies. You might want to change the child's environment to facilitate language development. So maybe this is very explicit, as in you and your kid are going to sit down and work on certain aspects of language. Like it doesn't have to be a formally scheduled thing. It can just be, 10 minutes of back and forth practicing sounds and specifically areas that are difficult and even doing some more recasting. You can be very consistent with it, and maybe that's a way to help. Okay, as a parent too, you have a child with DLD, you might have to pay more attention. So it's not just creating these circumstances and doing it like intentionally, going into it saying, this is my 15 minutes a day I need to schedule. Maybe it's just saying, like, okay, I'm in this like random time of the day. I see that my child is doing something, some activity that they're enjoying. So I'm going to start a conversation or engage with my child and use that opportunity to work on specific skills. So, it can be scheduled, it can be unscheduled, it can be impromptu. Okay, one recommendation for a lot of disorders is preschooling. So preschooling does cost money, of course, but it does put your child in a place where they can interact with other children at the age of 3 to 4 for longer times, usually like 3 to 4 hours a day, maybe 6 to 7, depending on the preschool. So that could create a very good environment for language learning and for social interaction. Okay. Again, there's always issues with things here. Like you can be like me, who went to preschool and spent the entire year not speaking a single word to anyone or any teacher in the class. I don't know how my parents did not identify me with having issues, but that was me. So maybe they don't want to interact. Um, and maybe the adults just don't have the time or attention, given how many kids they have, to actually help facilitate language. So they might not be able to pay attention to a particular child and help them develop their skills. Okay. So, even if preschooling fails, there is a benefit of preschool, which is like, let's say a child does not want to interact with people at preschool. Let's say teachers don't have time to, work on language with every single kid. But when you pick them up, you can have a conversation about what happened at preschool. So it gives them something to talk about that their parents don't know. So they have to learn to develop their own narratives. They need to learn how to put their thoughts together and, produce words and sentences that describe what happened. So it's a nice way for children to start that narrative development and get practice because they're engaging in conversation where it is sharing of new knowledge. So it's communicative. Okay, in terms of direct intervention, this is probably a lot more common than the first thought you might have if you're a parent with a child with DLD or any sort of language disorder, which is like, I need to see a professional. Okay. Um, there are many different programs for this. Every program is different. Okay, so sometimes it's one-on-one, sometimes they're very small groups of 4 to 5, sometimes they're very large groups of children. Again, it's going to depend on where you go. You can look at a lot of different programs available and talk to a lot of different SLPs. Okay, you might have children that are mixed with language delays and language disorders. So again, if you're targeting a specific thing at a specific age, children might appear very similar in those aspects, and they can be helped with the same methods. It's just that children with language delays will catch up without intervention, while children with language disorders probably will not. Okay, there are SLPs. There are also other like behavioral clinics that will focus like specifically on different language aspects. So it could be vocabulary and object development. So there could be programs that just teach kids certain words with toys, so more physical stuff. So again, like there's lots of different direct intervention programs, which we're not looking at in detail. We'll see some in the presentations, but again, unless you talk to people specifically, it's hard to get a nice detailed analysis of their specific programs. Okay, so what happens as kids with DLD get older? Well, unfortunately, as a teenager, because it's a disorder, you don't just get like caught up. This is again, it's a lifelong thing. So teenagers will still have issues. And this creates like a big cycle of more issues. So we could start anywhere in the cycle, but just to explain it generally, what's happening is one, a teenager may not know that they have DLD because they don't get a diagnosis. Okay. So then what happens is they have difficulties with language and they're put in the school system. So this school system is going to say, look, your child is not able to keep up. They're not doing well. Like you need to work on them with home to do these tests, like to study. But like the teachers don't know specifically what the issue is. And as a parent, you might not either. Okay, so that's an issue. So then you're like, okay, what can I do? And you search online and you realize, okay, there's actually not that much information on teenagers with language issues. So what do I do? Okay, well, I might take them to see a professional. And the professionals look at them and they say, well, we know how to deal with children, but not teenagers. So maybe because it's a teenager and not a kid, this is a behavioral issue. It's not a language issue. It's just a behavioral issue. Okay, but they maybe it is a behavioral issue, but maybe that behavioral issue is coming from a language disorder. Okay, so they're like, okay, well, it's a behavioral issue, so let's see what I can help with. And, the professional helps them and they just don't get the right thing. And then they say, well, what can we do? Well, we don't know exactly where to send your child, so we're not comfortable with language stuff. Usually we work with kids. You might want to see an SLP, but they might just recommend an SLP. Like, maybe look at that. Okay. And you recommend an SLP, and as an adult, you're thinking, okay, this is expensive, so I'm just going to do some more behavioral stuff with my teenager. And you don't get that push to see an SLP. Okay, so the cycle keeps continuing. It's finally you see an SLP. Maybe some things work, but an SLP who maybe isn't the most professional might come back and say you should have done this earlier. Or an SLP who's trained in children or adults may not have an understanding of intervention methods for teenagers. Okay, and then this flows back into the school system after this whole process goes. It's like, okay, we've tried our best. Now you're still back in school, and now you have issues because again, you still haven't solved the issue of the language disorder. You're just, you're in this cycle of like difficulty, neglect, and not being helped. Okay. And like we saw before, there can be risk factors from parents with DLD passing on to children. So this cycle may continue not only with the individual, but with the next member in the family as well. Okay. So of course, like when we say there's adolescent issues, like it's just under researched. It's not researched at all. So if you take a look at verb usage, there's a nice little chart here that compares TD children, which is typically developed with this SLI. So DLD in this case is just an older graph. We can see some trend lines. So take a look at the trend lines for older TD here, typically developed children. This would be this line right here. And if we take a look at older SLI, we see this part right here. So in the percentage of verbs used correctly, we may see that children, older children or adolescents with DLD, might not use verbs correctly as often as typically developed children. And the percentage of adolescents aren't necessarily catching up at the same rate. So there's a little bit of a gap in terms of how many adolescents tend to use verbs correctly 100% of the time. And of course, this is just a trending line. If we take a look at an actual plots on the right, we see that younger and older typically developed children are between that 50 to 65% range. So 50 to 65% of them are using verbs correctly 100% of the time, while DLD children, they're lower. Okay, adolescents will still have a lot of the issues that kids will have. So issues with tense agreement and other inflectional issues. A lot of it is behavioral too. So they might not appear to listen to their teachers because they might have difficulty processing what's being said. And of course, if they can't process what's being said and they have difficulties reading and understanding and comprehending, they may not be able to paraphrase things, which can affect their ability to participate in group discussions, sustain conversation. Their vocabulary and sentence structure might be very simple. And of course, all of these feed into other things. So especially in high school, middle school, when children and teenagers start to read books, they're unable to comprehend the point of the text because they have language difficulties. Okay, so then a teenager would write an essay. They get a low score. Teachers say, "Why don't you understand this? You didn't read it." Well, they did read it. They just, they don't have the ability to keep up in terms of reading because they have a disorder in the background. Okay, so there's some different tests here. These are different years. Some of these have been updated since, but I just want to show you one of these tests with different areas of language so you can take a look at them and you can understand what types of clinical tests can be out there. So this is a sample from the website for the CELF-5. I just want to show you some of these. So this is the clinical evaluation of language fundamentals. I'm not going to show every slide. I just want to take a look and show you what they look at. So this could be a parent or a teacher or a professional who is doing this evaluation on a child. So one thing is an observational rating scale. We know that DLD does have some behavioral related indicators. So we can take a look at it in terms of the behaviors that are related to language. So you might have different things like with listening. Maybe they have trouble paying attention or following directions or remembering things people say. And they can say, well, it's okay. Remembering things people say sometimes. Okay. They never follow spoken directions. Okay. And maybe one of these is done by a teacher, one of these is done by a parent. So it's just a very straightforward checklist here of different issues they could have. And if they're saying never or almost never or sometimes on a lot of these, then maybe that's a good indicator. Okay, they have sentence comprehension tasks. So I will show this. So maybe you get a picture here. There's a demo. So this is not the demo here, but you have a picture here and you're asked which picture corresponds with which sentence. So you might have the girl is being pushed by the boy. And then one of the pictures would be a girl being pushed by the boy, or he is ready to go to bed. And you might have a picture that represents that. So it's whether or not a child understands the sentence. There's linguistic concepts. So this is a bit of a bigger thing. So this is, of course, word recognition. So you might have a bunch of different pictures and they point to the word when they're asked to. In terms of word structure, this could be changing the form of the verb. So the boy is standing and the boy is. and then you point at a picture and you want them to say sitting. Okay. Or you're doing like a WUG test with real things. So here's one book, here are two, and then the child has to say cups or books, depending on what they're looking at. Sorry, the demo was here is one cup, here are two cups. The test was here is one book, here are two, and you'd say books. Or here are two more books. So that would be a score of 1 if they say one of those. Word classes, okay. Following directions, again, this happens to be with sentence comprehension and listening. So and this is like a word recognition task, but you're not looking at specific objects. You're looking to see if they can follow instructions, especially ones where it's not just one thing, but 1, 2, or 3 things. And there's different options. So it might say point to the circle and a square. Okay, well, there's only one circle here, but there's 2 squares. So, a child would have the ability to point to either of those. And there's there has to be an understanding of words there, of course, and to be able to follow the instructions and process that visual information. Formulating sentences. Okay, so as you look at a picture and you write down a sentence based on what's happening. Recalling sentences. So this is when you give them a sentence and they have to repeat it back verbatim. Okay, and then you track how many errors there are. So I say, my sister is in the 6th grade. Maybe like a young kid would say sister in 6th grade or sister in grade. So there'd be a bunch of different errors there. But you'd expect a child around the age of 6 or 7 to be like, yeah, my sister is in the 6th grade. Understanding spoken paragraphs. So this is a lot more about like working memory and cognitive capacity and the ability to process information. So you read a story essentially. So this would be a story here, and then you ask them questions about the story. This is not written. They are not reading this. They are hearing this. Okay. So you have to be able to remember the story. You have to be able to remember a timeline because they can ask questions about temporal events, and even like productions from certain members. Maybe they have a phrase that someone says or a sound that someone makes. Okay. Word definitions. This is understanding the robustness of meaning. So there is little left in the box. What does little mean? Okay, so there's some different meanings here. There is little left in the box. Okay, so maybe there's just a little bit left, or maybe there's not enough left. So either of those would be okay. Sentence assembly. I mean, if you've learned a second language or use Duolingo, you do this all the time. You have a series of words and you're asked to put them into a sentence. Okay, a simple task is just a declarative sentence. Another task is to say, okay, can they do questions? So can they make 2 sentences with these words? We also have semantic relationships here. So these are just understanding the language and being able to deduce things based on real world knowledge in the language. So trial 1, or let's go question 1 down here for ages 9 to 16. An hour is longer than, well, a minute and a second, but not a day and a morning. So they have to circle or choose these 2. Some deductive reasoning. Dan is taller than Jeff, and Lee is taller than both of them. So Dan is he taller than Lee, shorter than Lee, the tallest, or not the shortest? So they have to understand the language concepts and be able to reason with them. Reading comprehension. This is like the spoken one, but now they're taking a look at, whether the child or teenager, so age 8 in this example, can read a story and answer questions about it. Maybe there's some structured writing too. So of course, this is just like either completing the sentence and adding another sentence, or completing a sentence and adding 2 more. So it's not full essay writing. It's just, here's a quick prompt, finish what you see, and then expand on it. And finally, an example might be a pragmatics profile. So this is kind of like the observational behavior at the beginning, but this is like an actual task. Well, not necessarily a task that they're doing at the moment, but a task that would have to be done at some point where they talk with other people. So not a formal task, but an informal task about rituals and conversation skills. So the other one was listening. This one is more like, how are they doing it in social interaction? So are they responding to greetings from others? Are they beginning or ending conversations, or are they just walking out when they're done talking? Are they doing turn taking? Are they maintaining eye contact? Which again, a lot of these indicators might be something else. Our lovely friend Autism here, which we'll be talking about. Are the topics appropriate? Okay, so that was just one of the tests to look at, DLD. Again, when you do these tests, this should be done by professionals with the full version. This is just a sample for the CELF-5. So professionals, teachers, parents, like you do not do these on your own and create a diagnosis. You see a professional, they assign this to you, or they conduct this with you, and then they interpret the results using the specific coding guide for each test. When you interpret results for these tests, it is not as straightforward as just adding up scores. Um, Sometimes they are, but usually it's a lot more nuanced where they have programs on the back end where they take in all of the data input and it tracks commonalities and things for each individual question. So there's a lot more behind the scenes that a professional has to interpret than just numbers on scores, like just numbers and scores on questions. Okay, so even if you were to get a full thing on this, and you were to do this with your child on your own, you don't have the training to properly interpret results. Okay, so that's it for DLD in part one. Now we'll go on to part two. Okay, so this section, we're going to start with autism spectrum disorder, or ASD. So it was described as a syndrome in 1943, and there's a very interesting quote about this that I think is worth reading. Aloof and withdrawn with tendencies to communicate with repetitious or echoed utterances, fascinated by inanimate objects, and intolerant to changes in routine. So, yeah, I mean, some of these do happen. I mean, withdrawn, it depends on the person. Communicate with repetitions or echoed utterances, they can happen. I think fascinated by inanimate objects is a little bit, you know, judgmental and inappropriate, but intolerant to changes in routine could also be, um, pretty accurate depending on the person. Again, it is like a spectrum, so different autistic children and adults have different symptoms or I guess indicators, but it's this old definition 1943 isn't necessarily the most appropriate nowadays. So ASD has a biological basis. It is relatively understudied and unknown. We do know that there are differences in people's brains with ASD and typically developed adults and children. But for the most part, we're going to not talk about it because a lot of it is like there's no coherent, fully understood biological basis now. But we do know that it is rooted in biology. So what is appropriate is to say there's deficits in socio-communication, play, and behavior. Like that is totally appropriate. We're going to talk a little bit about behavior first, but then we'll talk about language as well. So it appears in about 1 in 68 children. I believe this number is even more common now, and now that we know that it is a spectrum. So what used to be like a very strict criteria that had an average of like 150 people, we've understood that there's more criteria, and not all autistic children have all the criteria. So we know a bit more, and it's become a little bit more common in diagnoses. In terms of what the actual population numbers are, we don't know specifically yet, based on all these studies, but as diagnostic tools get better, we have a better understanding of what the actual rates are. So some differences in the brain, which we can be loose about, is that there's an overabundance of brain cell connections in some areas of the brain. So there's just more connections than typical developed kids. Increased cerebral volume, excessive cell loss in some structures, and there's some enhanced activation in some areas of the brain related to thinking, feeling, and behaving. So in other words, the activity is different. There tends to be more activity in the brain with people with autism than typically developed people. So I think there's a common misconception about feeling, for example, because a lot of ASD, people with ASD tend to be less emotive or expressive. But what's interesting is that actually, in terms of empathy responses, autistic children and adults tend to score higher than typical development, but they just don't show it in the same way. So there have been some suggestions for what ASD could be caused by. They're still being studied, although some are probably way less likely than others. So low levels of vitamin B9 during fetal development could be something that contributes. Injury to the cerebellum during development could be something that contributes, although it's very unlikely given the rate at which people are diagnosed. And then environmental toxins, which are very underdescribed, but um, some people have said that the increase in rate is due to differences in our environment since the Industrial Revolution or whatever. So, you take these with a grain of salt until more evidence has come out. Okay. So for diagnosing ASD, there's like a couple big signs that are probably noticeable first, which is like issues in interaction and communication and like repetitive use of patterns and interests and activities. So these would be people who find a particular hobby and obsess over it for a long period of time, or people who just like very socially awkward and can't seem to pick up on like a lot of pragmatic, non-literal meaning or non-literal intent. So a lot of children can mask, and it may not be like obvious at an early stage because the child is just not in an environment where they would have to perform like like a typically developed person. So if someone struggles with pragmatic difficulties and they're never around friend groups, you're not observing an environment where you would observe that behavior. So a lot of this can be masked, and children will learn to mask just to fit in, depending on their level of social awareness. So there's some prototypical features. You can read some of these. So I'll post out something that are I guess something that I relate to that I can talk a little bit more about. Then you can read the others if you're interested. So one of these is deficits in social reciprocity. So does not initiate or respond to conversations, one-sided conversations, failure to respond to name. So I can identify with this one with initiating or responding to conversations. I'm very bad at initiating conversations. It is very anxiety inducing, to say the least. And that is something that, of course, uh, typical developed adults and kids face too. Um, but sometimes it's just I just lack a lot of interest in social communication as well. So I don't initiate or I don't respond because I'm just not interested in responding at the time. I don't want to communicate with people. Sometimes conversations are one-sided because as someone who had to learn, I'm very bad at talking about things I'm not interested in. So when a conversation goes to something I'm interested in, I can talk a lot and I can say things. But when it's not interesting to me or I'm not interested in the person, I fail to ask questions or make conversation unless I'm like really, really focusing and trying to do it. Like in an academic setting, I have to. There's some issues with eye contact, reduced facial expressions, turning away from speaker, abnormal prosody or volume. So, like, I'm a little bit more monotone than other people. I'm not as monotone, but depending on the circumstance, I can definitely be a lot more monotone than in other circumstances. Eye contact, again, you'll see this with a lot of kids and adults with ASD. I turn away my eyes to think. So, if I look at somebody in the eyes while I talk, I find it very hard to think. It's very distracting. So, that could be one explanation for poor eye contact. Others could just be anxiety as well. Could be other issues related there. Uh, Maintaining relationships appropriate to developmental level, difficulty making friends, does not take another's perspective, lack of interest in peers. So again, like these are behavioral, and a lot of this is social, and this will, in some cases, affect language. So B, restricted repetitive patterns of behaviors and interests for at least two of the criteria. So there's nothing really here that talks about language specifically, but one thing you'll notice with some people with autism is this atypical responses to sensory input. So like having extreme sensitivity to things like sounds or lights or movement or pain. So that could mean they're more sensitive or less sensitive. So for me, I have issues with lights, and depending on whether the sound is controlled by me or not, sounds like it's not a very straightforward thing. If it's music that I control, I can listen to it very loudly. But if it's like conversations or music from somebody else, like I get sensitive very fast. So it's going to depend on the person. But again, this isn't language related, so we won't go too far on that. Over time, uh, changes have been made to how autism is diagnosed and how different levels are created. So it used to be that autism was like something, this is someone who needs substantial support or very substantial support. And if someone had autism, but they were pretty well off and could function on their own, they called it Asperger's. That is no longer how this works. Instead, autism is three different categories. Level one needs like minimal support, and level three needs the most support. So, um, someone who is level one can probably hold a job, maybe with difficulties, but I mean, they can mask, they can function a lot like typical adults in a social environment or in the real world, but at home, the different behaviors might become more obvious. So, some impairments without support, difficulty with initiation or response to social interaction, and then some repetitive behaviors or things that may affect the environment that they're in. Okay, level two, this is when we get to see more support needed. So there's impairments in daily life that are very noticeable. There's very limited initiation and response, and a lot of the behaviors or frustrations that they have with the environment will interfere in their interactions. And then very substantial support. Again, I don't want to talk too much about stereotypes with children and adults, but I'm sure you've heard or met people who have autism that are in this category where verbal or nonverbalness can, nonverbalness specifically can cause a lot of issues, or even just the way they talk, how much they can talk. They're very isolated in some cases, and they really struggle with the environment. So it's not so much as like being able to go out in public and function with, like, say, headphones on for a few hours. Even with headphones and distractions, like it may be very difficult for them and cause a lot of anxiety. So if a child has ASD, every child is different, but there may be some other disorders that they might have. So, like, one is an intellectual disability. This is just a very broad, but they may struggle with reasoning tasks, pattern matching, any of the skills you'd see on like a typical professional IQ test, as professional as they could be. A lot of children and adults with ASD have some motor deficits. So, there are, in my case, there are muscles on my body that I simply like cannot feel or control. And the coordination can also be very difficult. So example, if I'm trying to like kick a ball or something, it is very difficult to do it even with repeated practice. Like I can do it, but it takes like a lot of mental effort and a lot of visual support to do it. While some areas are totally fine, like writing, hand movements, head movements, other things are totally fine. But again, this is very common, and the severity is going to differ from child to child, adult to adult. Processing sensitivity, hearing loss does affect a very small amount of people with ASD. Some have seizures, but a lot of children and adults with ASD do have some sort of language disorder. So there's something that they struggle with. And as we talk about them, I might be able to point something out. But first, early signs. So again, these are all clinical markers and indicators. You cannot diagnose just based off one or two criteria. You need to find a professional in order to have yourself fully evaluated. Some people do diagnose without professionals, but if you do that, you might not be getting the nuance that you really need to understand yourself. After all, there is autism, ADHD. A lot of these overlap, and sometimes it's just social anxiety, right? It's not autism; it's just other things that deviate from a typically developed quote unquote normal person. So from 8 to 12 months, you might find less frequent eye contact. You might have failure to respond to names. In terms of gesturing and verbal communication, this pointing and response might not exist as much. So it's not like completely gone, but it might be way less frequent than other typically developed children. So lacking pointing and lacking response is really like a communication thing. So facial responses, pointing, producing sounds back in adults. Some children with ASD actually don't make a distinction between environmental sounds and human voices. So an environmental sound can be just as loud, if not louder, than a human voice, and sometimes that can draw more attention. Sometimes due to like some children, again, with facial expressions, they don't really imitate emotional expressions or produce them that well. And then even reading faces and understanding social cues and facial cues can be very difficult. So these more subtle things can be difficult, even at a very early age. Okay. So turning to language, what do ASD children do well? Okay. So in terms of their phonology, it's usually fine, just as intelligible as TD children. Sometimes certain sounds will have difficulties. You might have like L and R becoming your W's. You might have S being a little bit more dentalized to make that lispy S, or it might even be more like an esh. And for the most part, phonology is fine and very on track. The morphosyntax, the structures are being followed. This is not a disorder where sometimes the morphemes are being acquired out of order, like DLD and that sense of disorder. We may be a little bit slower in some cases, but for the most part, like we will catch up. So this is not like a permanent just a delay in this case. Our comprehension tends to be fine. Children with autism might even be more particular about words and meaning than typically developed children. They might be less accepting of words that are used in ways that they have not learned them in. They may like suggest other words instead. So you can think about like maybe the whole object assumption being a little bit more limited and specific with children with ASD rather than typically developed children. And they can imitate just fine. In fact, they might imitate way more than a typically developed person, but the imitation ability is fine. So here are some deficits, and phonology is really more about the prosody here. In fact, that might even be a better label when you think about what these actually are. So in terms of speech, it's a lot of like control over volume, pitch, intonation. So rhythmic patterns to speeches using like the same sort of, yeah, the same rhythm for all of their sentences and patterns, quieter or more whispering than normal. So they may find it hard to project, like projection may be very tough for some children. On the other hand, they may be very good at projecting and be projecting too much in too many situations. So someone might be overly loud, or they could even go between loud and quiet back and forth without really being consciously aware. More monotonous speech, so less variation in pitch. Some people stutter. I do. When I was a kid, I used to stutter quite a bit. Now I do stutter, but I replace it with pauses and with ums or repeating myself just as a strategy that I've learned over the past 10, 15 years. So you can start as stuttering and maintain stuttering throughout adulthood. Some children do. Others will, make adjustments. And, if you're having difficulties with speech and intonation and rhythm, sometimes the intonation is just not right. Okay. In terms of pronouns, this is interesting. This is not anything I've encountered with people in the real world yet. But it does happen. I think less so than some of the, definitely less so than the prosodic differences. So difficulties with understanding like gender and inflection on some pronouns or case. So really you can think of it like just sometimes there's an inflectional issue with pronouns. What's interesting here, I didn't talk about, I just went through, but using you to mean I or me. So in other words, knowing that other people say you to refer to yourself, some autistic children believe that you is how they should be talking about themselves too. So like not understanding that perspective shift. Okay, formulaic language and neologisms or neologisms, however you want to say this. In other words, like the creation of new words. So you repeat things that you hear. You might even say things out loud that you read. So if a child can read at a young age or a teenager, when going by a sign, they might just read what they see, like in a car ride, looking at billboards or something, or reading the names of stores that they see. What's interesting is that they found that with a lot of children with autism is that they store like phrases, particular phrases in their mind that are high frequency, and they don't understand their components, but they understand how to use them as a sequence. And that sequence always comes with like the same rhythm, the same tone, the same intonation. So it's as if like a set of words is just learned as a lexical item that always contains that same prosodic information. Uh, and what is really interesting um, for kids who are very particular about language in some aspects, or in some cases, they create new words way less often than children with typical development. But when they do create new words, they usually create new words from the pieces that they already know rather than creating new things. So if you create like an object, there's like this thing and two things like this, and then a thing like this. If I wanted to give a label to this, or an autistic child wanted to give a label to this, they'd more likely use morphemes and parts that they already know rather than make something up like a kluba or something. It'd be like a duo stickball. I don't even know what to call this, but something more known to them already. Okay, communication. Compared to DLD, children with ASD are very good at following requests, so they can comprehend what is being said, and they're also very good at asking for things or saying things to change someone's behavior. So they're very good at understanding some of the patterns that come with speech. They're not good with the intent behind speech or the hidden subtext, but they're very good with knowing what types of words and phrases might elicit some responses. Now, again, this varies from person to person, but if they've experienced a pattern repeatedly in the past, they probably understand that pattern pretty well and they can use it. We do have issues with gaining attention and directing attention. Sometimes this is just volume control. This could be related to timing, relevancy. So a lot of pragmatic factors here. Same with initiating conversation or joining conversation. Again, there's a social aspect to it that can be very difficult. Another thing is that a lot of people with autism don't actually care that much or register social status or professional status or authority. So if we talk to like I don't know, like the president of the university or a professor or a peer or like someone younger than us, it's most of the same language comes out. Some people are able to mask, of course, and they're able to make changes, but overall, there's no subconscious thing that is telling a lot of people with autism to change their behavior around certain types of people. So, whether that makes us more or less relatable, that's really up to the person there. So this can be a difficult for adults with ASD, especially trying to understand the workplace and trying to understand power hierarchies. Okay, so how do you intervene with children with autism? Like, is it even something that you can improve? And the answer is yes, you can make improvements for children with autism depending on the level of support. You can make some improvements. Of course, someone who's level 3 who needs substantial supports is probably going to take a little bit longer and make improvements that are less as extreme as someone who's like a level 1 support and maybe has like this an interest in behavior, an interest in humans, or an interest in changing. So there's a checklist for autism and toddlers called CHAT that look at things like eye contact, joint attention, and pretend plays. Of course, depending on the task of the child, it might not be super useful, especially around 18 months, since like children with ADHD or ASD or some DLD might not even be able to do the task or listen to the instructions or understand the task. Okay, So a very common thing is a behaviorist approach. I know there are some people in this class who have worked with children with autism as a behavioral interventionist, so you can probably say a little bit more about this than I can. A lot of it is just working on certain language behaviors or certain aspects of language step by step. So having clear goals, um, sometimes playing games with it, sometimes playing like a circumstance, like different circumstances, role playing things like that, and just really help me motivate and celebrate changes and success. So this isn't, and I know there's like this sometimes a negative view on this is like you're just trying to make these kids more normal, like you're trying to assimilate them to normality. But really, this is just a strategy to integrate into society because unfortunately, like there is a typical behavior that is expected of everybody. So these behavioral approaches sometimes are aimed at that, but most of the time, it's like here's a behavior or here's a language issue that is really going to impair you or is impairing you, and we just need to help you with that. So they're not bringing someone who's like an 85% up to 100%. They're bringing someone who's like a 15% up to a 30 to 40%. Okay. So sometimes it's like appropriateness. So for example, an inappropriate behavior, if you think about language, might be like when you can say certain things or you cannot say certain things. Um, I have definitely experienced people who I know who have said very inappropriate things in places that they shouldn't have, um, who are definitely on the spectrum, but were not diagnosed. And if I could repeat them, I would, but it's not appropriate. So before it used to be like a punishment, but a lot of behavioral approaches aren't so punishing, but instead um, more motivating and supporting and trying to explain why or where you say these things and like what's okay and what's not. Okay. Of course, this isn't going to always work. Like these are not children with ASD are not objects. They're humans with feelings, emotions, and intentions and interests. So some people with ASD might just not care and say, "Listen, like I know this is what I should be doing and what is appropriate, and I understand that, but I don't care, and I'm not going to change myself because I don't care what other people think." So that can happen sometimes. Okay, another approach is the social interaction approach. So this is, of course, an interaction. So this is like outside of working with an SLP or behavioral interventionist, sometimes just parents. So this is really focusing on how other people interact with children with autism. So parents are a bit of an issue because adults and parents learn their children very well. They know their patterns. So when you learn that your child responds to certain things well, then you tend to do that more because you know that will elicit more responses. So if a child is really only interested in, let's say, learning about animals, and the only time you can get information or verbal communication is when you talk about animals, adults may say, okay, I'm only really going to talk to my child when it's about animals or it's like a warning or instruction. So that's very limiting to the input that a child can get and it is not going to help them develop. It's just going to teach the child like this is when I respond. This is when I talk. Okay, some approaches are working with schools to help children who are typically developed understand children with autism. And a lot of it too is floor time. So especially when kids are very young, having parents sit down and interact and play with them, just like really any child. But even perhaps focusing more on specific things or keeping conversations going or just talking more, asking more questions. So just really teaching that social behavior and just letting a child explore with that. So there's some intervention practices that we can see, just like quick snapshots of them. I'm not really going to talk really about most of these because we've already talked about them. I will talk about functional behavior assessment though. So this is identifying negative behaviors, identifying what things trigger those behaviors, and then trying to understand um, those behaviors so that way you can work with that. So um, autistic children could sometimes have a lot of difficulties with self expression and also even understanding their own emotions or understanding what causes certain things. So there are some areas where having someone else intervene and try to understand your triggers and explain them to you can be very helpful. Again, just like some people can't feel or coordinate certain things in their bodies, that does happen with emotions too, in terms of identification and communication and understanding. Okay, parent implemented intervention. So helping parents understand what to do, very useful. Parents are going to be around kids all the time. So teaching parents can be very useful for that. Um, and then self-management too. So like, again, autistic kids are autistic kids. Like they have functioning brains, they can do very well, of course, depending on the level and support needs, but you can teach autistic children what is appropriate and what is inappropriate, and like teach them to monitor behaviors and create goals and things like that. I mean, they're kids. Okay. So that's ASD. I want to briefly talk about this side thing called SPCD, or social communicative disorder, or sociopragmatic communicative disorder, depending on what you look at. So this is separate from the autism spectrum according to the DSM standards, but it is variation. So some people have said that this is like the extension of what was known as Asperger's. A lot of people would say that, well, Asperger's is actually just level 1 autism. So again, there's some controversy here. So these are just kids who really have difficulty with, like the social side of things and the pragmatic sides of things. So non-literal meaning, communication, conversational abilities, eye contact, but all of the other language related things and behavioral things are typically developed. So it just seems more like someone with autism that does not have certain traits. Okay. So SPCD specifically focuses on communication, some comprehension deficit. So understanding communication unless the relevant points are explicitly stated. So in other words, they cannot read in between the lines. And again, children with ASD will have this too. So some people with autism don't understand humor or idioms or metaphors. So they may need a little bit more work to get them or to have them pointed out. Or they can just be taught that this is an idiom, this is what this means, and you use this in this sense. And they may be able to understand and use that chunk. But I mean, they might not even want to use that chunk and instead use more precise language. Okay. So that's it for autism and SPCD. SPCD. So as you can see, a lot of it really is just pragmatics and conversation. And a lot of behavioral things too that I think are more important for psychology than for linguistics, but are really interesting to know. Now we'll move on to ADHD and cleft palate. We don't have that much on ADHD, but it is interesting to look at. A lot of it comes from attention difficulties. So there's two categories of ADHD, which is inattention, so not being able to focus or follow along with task or listen. And the other is hyperactivity or impulsivity. So being like overactive. So a lot of fidgeting, a lot of movement, maybe speaking out of turn. So not being able to like time your turns or being relevant for turns. So like these are two different parts of ADHD. So if you focus on language intervention for ADHD, it's not the best thing that you can do. ADHD is definitely more behavioral with attention and impulsivity. So that's more like a behavioral psychologist rather than an SLP. This is one of the most common misdiagnoses for children with DLD is getting ADHD, and getting an ADHD diagnosis just because of the difficulties with understanding and comprehending language and all of the different factors that come along with that. Yeah, so like when you talk about ADHD, it's like, yeah, it's interesting linguistically. There might be some linguistic issues that come about, and it's just a lot of stuff that we've seen before, but a lot of this is just behavioral. So like there is more to ADHD, but I just don't really want to focus that much on it. So I will find articles if you're interested more on the language side of things. But there's nothing really new here that you haven't already seen before. So we'll move on to cleft palate. Okay, so on the next slide for cleft palate, I have blocked out the image here because some people might be sensitive to it. Again, it is some malformations, I guess, in the face and mouth. It might be sensitive to some people. So if you are doing SLP, you want to do anything in biology, neurology, you should probably download the slides and delete the box and look at it, or Google Cleft Palate. If you're not interested and you want to avoid the squeamishness or you have sensitivities, you don't have to delete the box. You can just keep it here. Okay. This affects about 1 in 1,000 children. And basically what happens is there's a deformity in the midface. So usually in the nostril area right below these, the top lip is separated, and sometimes the nostril basically just forms into one. So there's like a full, not a full, but it's not fully developed in the upper lip region. And if you go inside the mouth and you take your tongue and you put it behind your teeth and drag it all the way back, you can feel that palate there. And these children will just be missing that palate in some areas. So if you want to see an image, that might help a little bit more than my description, but if you're really squeamish, then don't worry about it. So children with cleft palate do have a high risk of intellectual disability if the syndrome has other issues. Okay, so just having cleft palate alone is not really affecting the mental. Children with a cleft palate might also have hearing loss. Again, if there's issue in the palate, there might be issues in the ear as well. And as far as surgery goes, cleft lip and cleft palate can be fixed, usually 10 weeks, but before 12 months. So it is caught very early. Once it is done, there's a lot of recovery time and limitations in what children can do. And as far as language development goes, it's really not studied too much. There are a little bit of delays due to the lack of verbal responses, typically after surgery for a bit. There's some development in terms of motor movement, but overall, it just slows progress. Children still catch up, typically. Okay, the big thing you would imagine is if there's difficulties in the mouth, you're going to have issues with speech production. Okay, so that's like going to happen. Usually the surgery is done when children are babbling. So yeah, they're not going to get that same practice as they would before. And even if they do that practice, they're going to have difficulties producing a lot of sounds. So plosives, for example, are going to be very difficult because, you know, you're missing part of your palate. So you might just get more nasal sounds where air is going through the nasal cavity, or glottal sounds, which are more in the throat where the palate is just not affected. Bilabial sounds, again, can be affected because of the way that the upper lip can be affected. Okay, so disruption in speech production is going to affect your speech. So once the surgery is done and they produce sounds, they're going to have difficulties until it can be corrected. And some children at 3-4 years old may still experience some issues with that and may need to see SLPs to work on that. Okay, so the last slide for this section is the differences with typically developed children. So for kids with cleft palate, they'll use more words that start with sonorants. Again, have difficulties with obstruents. And sonorants have equal air pressure inside and outside the mouth, which means like there's no obstruction. So, you know, if you have issues with your upper lip and cleft palate, that just makes sense. So more nasals, approximates, and vowels. These don't require particular articulation or place points in the palate or teeth or upper lip. Children do to catch up typically. And yeah, because of the issues with not being able to practice speech around the typical time that children start in that 6 to 12 month range, you might see some lagging behind with any vocabulary in both production and comprehension. Like as we know, production is very important for understanding words as well. In order to fully grasp the meaning of something, you should both use it so you can get feedback that you're using it appropriately. Okay, now we'll move on to part 3. Okay, this last bit focuses on Down syndrome, fetal alcohol syndrome, as well as acquired aphasia, and then a little bit on feral children and quote-unquote gifted kids. So we'll start with Down syndrome. Most people with Down syndrome can be identified with sight, but you know, we want to ignore facial characteristics for this. So typical symptoms would be motor delays, oral motor problems, which is going to be a problem for producing speech, visual problems, and then a pretty high rate of comorbidity of cardiac problems. So people with Down syndrome have a lot of high risks like diabetes, gastrointestinal defects, sleep orders, and dementia. Okay. So besides language, there are a lot of issues that can arise, unfortunately, for people with Down syndrome. So in terms of their language, their receptive skills are much better than their expressive skills. So they have good understanding of conversation. They know words. They understand gesture, and they can do imitation. Again, people are people. A lot of the comprehension skills are very good. It's just sometimes the expressive skills and the motor skills tend to lag behind. So if we think about their mental age, a lot of their skills in production, like as far as narration, vocabulary, pragmatics, it is pretty on point for their mental age. The usual deficits are in the more complicated things like processing phonology, um, a lot of this different expressive vocabulary for feelings, emotions, reasoning can be difficult for some people. Very complex syntax structure, negation, and topic maintenance. So things that require a little bit a little bit more developmental knowledge to do. So further stages in development, I guess we could say, in the typical chain for typical kids. Okay, what's interesting, and again, the problem with a lot of these syndromes and disorders are that what you see from the behavior of the person can sometimes influence how you think about um, how they would process language. So, children with Down syndrome tend to have reading skills that are on par with typically developed children. Okay. But a lot of the expressive bit, like the writing skills and the interpretation and the communication, might likely be behind. Therefore, you would think that the reading skills are not on par. Okay. But in general, reading skills are on par. Um, a lot of the intelligibility issues that lead to this are, speech production and hearing. So again, there's oral motor problems, which are going to cause uh, a lot of those speech difficulties. Okay. The error patterns are not typical and they are inconsistent. So what this means, if you think about this in terms of typical children, usually the error patterns are pretty consistent unless they're like switching their light switches on and off to test different patterns. And that would say that they're playing with the grammar. But when error patterns are atypical and they're inconsistent, usually this means that, the grammatical pattern may actually be known, but there are just other issues in the background. So they've like acquired languages, whatever language they speak, but there's difficulties in some other area that's making these errors inconsistent or unusual, and it might not always just be strictly language related. So there is some overlap with Down syndrome and autism spectrum disorder, but only about 10%. Okay, so with intervention, tasks can be quite challenging because of the phonological processing speed, as well as like other potential intellectual difficulties, like with working memory, expression, and so on. So you may do simpler tasks like repeating words or repeating instructions or using more picture-based tasks rather than communicative language tasks. So when you're doing these tasks, obviously the types of language that you can target are quite limited. So you'd be doing like vocabulary, grammatical morphemes, and practicing phonology more so than targeting things like complex sentences or topic maintenance. Some parents do choose to work on writing skills with their kids. But again, like with some motor difficulties, writing skills can be quite challenging. So other people opt to improve on typing. And there's been some evidence that typing tends to be easier than writing when it comes to motor deficits. The fine-tuned muscles needed to write are a little bit more fine-tuned than what you need to type. And the thing with typing is that you don't need to use all 5 fingers, right? You don't need that fine motor control. You could just move your wrist and hunt and peck. There are many different typing strategies that might make it easier. So with fetal alcohol syndrome, um, some kids can be identified by sight for this, but that is not the norm. So it could be short nose, flat mid face, a thin upper lip. Like there are signs, but it's not something that is as common as say seeing Down syndrome by sight, which I think is again not always 100% easy to tell, but for the most part, it's the visual differences are much more prevalent than children with fetal alcohol syndrome. So the health risks are not great, which is a good thing. Like there aren't a lot of health risks for children with FAS. Typically, when they're born, they're very small compared to other kids. Like they'll weigh less, they'll be much shorter, even as a newborn. And they do have some neurological and functional abnormalities in the central nervous system. So, again, we're not going to talk about behavioral things or biological things, but we do want to talk about the language. And this is quite interesting that children with fetal alcohol syndrome typically score lower than typical developing children on a lot of different tasks with language. So, abstract language problems, negotiating, resolving conflicts, maintaining friendships, narrative language, mental state, verbs, perspective taking, and there's a lot of overlap with attention deficits like ADHD. It is not necessarily ADHD, but there are some attention difficulties with a lot of kids. And as you can see here, these are a lot of symptoms that overlap with ASD and in some cases DLD, depending on the person. So, like I said, if you just take a look at language alone, there's no way you can like diagnose a child with a specific disorder unless it's like DLD. So, what you'll notice is that a lot of this isn't like small aspects of language like phonology or tensor agreement or the development or acquisition of morphemes. These are more higher level pragmatic difficulties that children seem to face. So a lot of the social factors here, and then a lot of the putting people in other persons in other perspectives, which has like some overlap with ASD. So because of this, a lot of the intervention methods focus on social processing and communication behaviors. In other words, like they're focusing more on the social aspect to target those areas of difficulty, like maintaining friendships and resolving conflicts and negotiating. So they do sometimes struggle with complex syntax, so you might have comprehension and production of complex syntactic structures. And to get that narrative right, you get some cohesion and coherence as well. So uh, children who are experiencing this can be helped with early intervention. So focusing early on literacy skills, reading books, telling stories can greatly reduce deficits older in age. Okay. This next one is different because this is a problem that children are not really born with. Um, so this is like a child is born and then there's some issue that happens. Either there's like a traumatic brain injury, so due to an accident, or there's just some neurological functioning issue that wasn't apparent early on. So a child is typical until this disorder is acquired with acquired aphasia. And um, difficulties, depending on the person and depending on the severity, the difficulties might be lifelong, while in another case, some people might recover. It really depends on the injury and the cause. So it's usually acquired from TBI. So traumatic brain injury, if there's no oxygen in the brain, if your axons aren't working, signals aren't being sent, if you have issues with nerve cells, or there's like some overstimulation. So here's some information on here with TBI. Yeah, I don't think I need to go over this. Anything to do with brain damage or traumatic brain injury is going to cause issues in a lot of places, as you could probably imagine. So you may have delayed motor milestones, you may have issues with short-term and long-term memory, processing, attention, visual details, motor speed, judgment, anger outbursts, so like emotional issues, reasoning issues, socialization issues, withdrawal issues. Again, it's going to depend on the person and where the damage was. So there are some common trends that we see with people with acquired aphasia. One is difficulties with comprehension depending on the severity of the injury. So if there's mild TBI, usually this isn't too bad. Not too many people are affected, but with severe TBI, there are a much greater population that experiences these issues. So one is poor comprehension of complex syntax. You might think like relative clauses or longer sentences with multiple dependencies. Some people with severe TBI have a lot of issues with recognition for words, while very few people with mild TBI experience this. And understanding non-literal storytelling. So again, with mild TBI, this is not really an issue for too many people, but with severe TBI, there's a lot of issues with just understanding non-literal meaning. I mean, really every aspect of language in terms of comprehension and processing can be significantly problematic for people with severe TBI. Okay. So one issue here is word retrieval. So this is called anomia, and this doesn't change depending on the severity of the injury. So people with mild TBI and severe TBI tend to experience the same rates of anomia. So about 20% of people have difficulties retrieving words from a specific syntactic category. So a lot of categories may be okay, but someone might struggle with, like, say, nouns. Someone might struggle with verbs. It's a really interesting phenomenon. It kind of tells you how categories are stored in the brain. Fewer words produced from fewer categories compared to TD children. So in other words, there's a lot less variety in the amount of words, amount of different words that people with acquired aphasia or anomia say. And there's also fewer categories, so they might use a fewer range. You might find people who just don't use adjectives or adverbs, like they don't use modifying words. Okay. Sometimes you get semantic paraphasias, but this happens. I guess I would like to say this happens with the general population too, but that's actually not that true in terms of prevalence. But again, this isn't really an anomia acquired aphasia thing. It just somewhat happens. So this is when you might have a word like, let's say, happy, and you're searching for the word, but you can't quite retrieve it. So instead of saying happy, you'll pick something that is very close to it. Like you might say, instead of being happy, like smiles or something. I was feeling smiles. Okay. In terms of difficulties with syntax, you're going to get smaller and shorter utterances, so speaking a lot less, and there's going to be a lot of difficulties in getting the sentence out. So pausing, starting with the inappropriate word that you wanted to say, and then constantly going back and revising your sentences. So really any task with production is going to be pretty stinted. Okay. In terms of TBI, again, there are cases where children have gone mute after TBI but recovered after. This isn't the norm, but it does happen. So that might be just children who just can't produce anything after experiencing a traumatic brain injury. But usually the production is still possible. It's just riddled with these types of errors and difficulties that we see. Okay. In terms of production too, that was mostly on understanding and producing sentences and words. But let's talk about the actual intelligibility. Okay. You're only going to experience speech intelligibility issues if your traumatic brain injury is targeting like the motor areas of the brain. And from there, you can get the sound substitutions, omissions, distortions, slurred speech. In other words, just any type of speech error you could think of is something that could happen. But the production of sounds is one of the fastest recovering symptoms of TBI. So the brain tends to repair this production pretty fast, much faster than the other areas where you might not be able to retrieve words or produce complex sentences. Okay, so as a child or teenager recovers, they go through several different stages, so early, middle, and late. And I'm not going to point out everything here, but very early on in the recovery, we get inconsistency in language comprehension, simple gestures for communication, and then you might have other issues with unintelligible speech, echolalia, so repeating things that you hear. So those are the speech ones. Going through about the middle stage of recovery, we get information and processing and language comprehension coming back, but it's limited to small words. We have difficulty with word retrieving and losing a train of thought. And then some more conversational pragmatic difficulties. Then late in the recovery, we get the ability to learn new skills and information slowly. We get it mainly difficulty with non-literal language. So the abstract stuff and the implicit stuff is a little bit harder, but the words themselves, the sentences do get better. And then we get a lot of error recovering and word finding problems being resolved. But they still might have difficulties with retrieving words and then also learning new words at that time. So this has a huge effect on children's school life. I mean, obviously, if you experience any sort of traumatic brain injury as a kid or an adult, it's going to have effect in the real world. So, uh, with children specifically, they may not understand or be aware of the issues that they face. Again, like you're not always aware of the brain, of the issues that your brain is causing. So, the limited self-awareness there, which can make things really difficult for children because they think they're communicating well, but really they're not. Um, Difficulty in initiating conversations. Some of this is confidence related based on the reactions. Again, because you have a little bit less control of your decision making and it's not working as well, you might get inappropriate remarks coming out. And with any sort of reasoning or planning skills, it may be difficult to think in multiple ways about problems or summarize things or identify things. So a lot of retrieval issues here, planning skills, motor issues. I mean, again, if you have a brain injury, a lot of different things can happen. And a lot of that is going to directly affect language because language is how you communicate your thoughts. So if your other areas in your brain are having issues, then of course that's going to affect how it comes across in speech. Okay. So with intervention, if you do any sort of intervention, you're going to get a test for TBI first. You're going to get your cognitive skills test. You might get your linguistic skills test. It's part of it, but you might not get like a super in detail linguistic skills test until you see an SLP. Of course, with a TBI, you're seeing multiple professionals. You're seeing probably your doctor, a neurologist, you're probably seeing an SLP, so you're seeing a few things, definitely a psychologist or therapist in order to get through some of the mental and social issues you may be facing. You, of course, have other things like nerve issues you need to work on. And of course, you always need a good support system. So, a lot of the intervention first is, of course, getting your body and mind working before training your language skills again. And a lot of that is coming back into school, right? Because you need social interaction to help recover, to help fix your mental at that point. So it's usually a very, very slow reintegration back into school. So hopefully it's not more than an hour or two a day at first, especially if you're recovering, but you're doing some very specific small tasks. You are working either by yourself or in small groups, so you're not overwhelming someone with lots of information and noise and a lot of necessary communication. And hopefully, you also have the support of some teacher or specialist in school that can help engage you by not always requiring verbal responses. Again, this is a recovery process, so you can't expect a child with TBI or acquired aphasia in this case to um, be functioning like a typically developed kid. Okay. As far as later integration, again, it just depends on the recovery process. This is a very complex issue that it's not just an SLP that does, but it is something that SLPs do deal with. So just being aware of some of the different issues that may have, but I would just remember for acquired aphasia, for any TBI related issue, brain damage is, of course, not just going to target the language center. It is going to target everything. And the language center is that communicative area where you're going to see a lot of these issues come out. So there may be some specific things you can fix and help with. But again, a lot of it's just through the recovery process and restoring all of your other functions alongside it. Okay. The last bit on feral children and quote unquote gifted children. So you may know Jeannie. You may have heard of Jeannie. Jeannie is a feral child, which means that she did not get good language input or interaction from a young age. So a feral child is basically someone who has not developed language at a young age and then struggles later in life to learn. So her story is not great. She was locked in a room from about 20 months until she was 13 years old and 7 months. So a little bit more than 11 years of her life, she got very little to no interaction. She did not acquire language because she didn't get any input during any of her critical periods for any of her parts. Um, she is still alive and she has learned how to speak, although of course not as well as anyone who has received language input during their critical periods for all of their areas. But she did recover, relatively okay later in life. So, feral children are just people who are not getting enough input during the critical period and they have difficulties with language long term. So it's not always a case of some parent or figure being abusive. Um, here are some stories of other people who uh, have been dubbed as feral children. So Andrei Tolstik, raised by dogs from 3 months to 7 years, behaved like a dog, did not pick up language. Ho Vai Long was a kid who um, had to grow up in the jungle by himself, fleeing the Vietnam War. So he lived in the jungle by himself for 40 years and um, didn't really acquire much words or language. I guess there was some acquisition by the father before he was left, but uh, language was not developed. To me, this sounds like a folk's tale at first, but I believe this one is true. And then finally, Sasha T left in a room with goats his entire life by his mother and not learning how to speak. So, feral children, sometimes it's just isolation. Sometimes there are these stories where children are left in environments with animals or, with no other people surrounding them. So, again, the truth of these specific stories is not as strong as Jeannie's, but, for the most part, I believe we can still take them as examples of how feral children could come to exist. Okay. So, I mean, with feral children, if I need to summarize for language problems, there's a ton of problems, and you can't really describe any of them in particular because there's just no or little to no input at all. So they're just not picking it up at all. And at that point, you need to learn a language as if it's your second language with the adult brain that you have. And that's very difficult if you don't even have a first language in the first place. Okay. So the last thing is gifted children. So gifted children are undefined, and I believe they always will be because I don't believe there's such thing as a gifted child. I believe it's probably just something else in disguise or incredible interest on something, but it's someone with exceptional abilities in certain areas. So they is not limited by age, gender, race, socioeconomic status, ethnicity. Like it can be totally random. Gifted children just exist. There's nothing that creates a gifted child. They just exist. So usually when people talk about gifted children, they talk about the 8-year-old who can do math at a college level or who is making groundbreaking discoveries in physics and astronomy at the age of 11. Okay. But if we really want to talk about gifted children more generally, we should just say it's really any child who has very advanced development in one area. So it could be something creative, it could be something academic, it could be something musical, something social, like it could be any particular aspect of life that they just excel at. Okay. So the tendency is to say, well, gifted children are people who tend to show unusual skills, abilities, or talents and make independent contributions to a field. But I can guarantee you that what's happening is, first of all, these people who make these things are sometimes associated retroactively with being a gifted child. But also, when a gifted child is found or presumed to exist in the wild, a lot of extra support goes into that gifted child. They get a lot of attention, a lot of support, and that leads them to some advanced development just because of their support network. So, that's why I say gifted child is probably not a real category of people that exist, and it's probably just something else in the background that we don't know yet. So there are some symptoms, I guess, of being a gifted child. I don't even know if it's a good thing or not, considering all of the social isolation these children feel. So I'll call them symptoms. Um, so there's communication issues, their creativity and sensitivity issues. I shouldn't even call these issues. They're benefits. They're benefits for these children. Intellectual playfulness, form mental images of objects, unusually aware of impulses and open to the irrational, may have intense interests. This sounds almost like autism. I'm not going to say that formally, but there's a lot of overlapping things here with some level 1 autism children. Uh, the big thing that stands out is really learning, which I think is what makes a gifted child gifted. So quick mastery, quickly grasp new concepts, goal-oriented thought, rapid insight into the cause-effect relationship. So in other words, they're just a really, really good reasoning, really good memory, and really good integration of ideas. Okay, so I say integration of ideas because they transfer learning easily from one situation to another. In other words, they're making connections. They have a lot of connections in their brain. So it's really just a child with like exceptional reasoning and planning skills. So gifted children have been called precious talkers, where the average age of first words is 9 months, and some even talk at 6 months. Of course, this could be exaggerated by parents. And you might say, my child is talking at 9 months, therefore they're gifted. And they just get labeled as one, but they don't track them far enough in life to see if they're actually following a pattern. Okay? And because of these average age of first words is so low, you get very fast acquisition of syntax and big vocabulary at an early age. So, first words being early also leads to better syntactic development. They're a little bit more advanced in their knowledge of abstract words and word relationships, so they understand the ideas between words. And if you were to put this together into one idea, what you really see here is really good pattern matching and really good connections between concepts in their mind, and they're able to express those in words. So altogether, again, they're just children who are very good at pattern matching and reasoning. Okay. In terms of pragmatic development, they say it has not been researched well, but it's expected that gifted children are on par with typically developed children in pragmatics. And I believe if more research is done, you would actually find that gifted children are worse off than typically developed children in terms of pragmatics and social, social ability. Again, that's just a theory, but considering a lot of the gifted children talk tends to be about specific level 1 ASD undiagnosed or diagnosed children at the time with intense special interests and really great pattern matching skills. I believe a lot of the pragmatic things you would see for the ASD side would be shown here for the gifted children side. Again, I'm not saying that as necessarily fact. I'm just saying this as a as a somewhat educated hypothesis. Let's say that. Okay. Now the last thing to talk about for this is advanced reading and writing. So you may think if you have a gifted child who's great in language, they're going to be really good readers and writers. And maybe it's because they read so much that's why they're so good at language. But actually, if you take a look at all the gifted children out there, according to what researchers call gifted children, overall, they're less interested in reading than typically developed kids. Okay. It's just that when they start reading, they tend to acquire their reading skills, vocabulary much faster than typically developed children. So again, I think the information processing is just very high, and you have, good memory. You're able to make connections really well. Okay. And when you get gifted adolescents, so when these grow older, they tend to be more effective in reading strategies. So they focus more on understanding, summarizing, connecting ideas, rather than kids around the same age who are still focusing on just comprehending precisely what the sentence is. They're spending so much time reading every single sentence and every single word and just trying to understand what is being written on the page. While gifted children can do that much faster, so they can focus on the more advanced techniques. Okay. Again, it's a bit of a whirlwind, just showing you all of these, just making you aware of some of the behavioral issues for each of these, some of the language issues for each of these, and then showing some of the intervention techniques. Again, a lot of this is very much higher level rather than very specific details. Just because if you were to do SLP in the future, or you work with a behavior interventionist, you really get a much better deep dive into one specific thing. You're kept way more up to date with what's going on, and you can actually see these things in the real world and adapt. If you try to do any of this on paper, of course, you'll run into roadblocks eventually. So just getting a good overview of what's going on, I think, was the most important here. So that's everything. If you have questions, you know where to reach me.